EXEMPLAR, disseminated intravascular coagulation. Endothelial layer of blood vessel. A thin layer of cells that line the inner layer of the blood vessel. Release substances that control blood clotting, immune function and platelet adhesion. Could be put in an IV. This could be some kind of trauma. This could be an infection, and it would release substances that control blood clotting, which is the tissue factor or factor 3. Tissue factor, aka factor 3. After vessel injury, tissue factor activates the coagulation cascade. Coagulation cascade, let's go. What happens is there's an overall response to it, and all of the clotting cascade gets activated, and this could be like, a paper cut size wound, just a little pinprick or something, and it ends up using up all your clotting factor. So what do you think happens? You're overusing your clotting factor. All of them are being used up as causing clots, so you have two opposite problems. You have clots where you don't want them, and then where you need clots, you don't have them, so patient can bleed out from a paper. Direct pressure to it, and you're going to be looking for signs around IV sites. They're going to be oozy, they're going to have that ecchymosis in places, and then you want to make sure that they don't get injured because they don't have any more clotting factor to clog it up. And one of the things to stop this is actually heparin, which seems a little counterintuitive, but heparin actually interferes with the clotting cascade, so we can free up some of that flying back there so that it can be used in other places. It's not always heparin that they use, but sometimes they have to do it, especially with chronic DIC. So those are your oncology patients or patients that have long-term problems that are causing DIC. DIC. Clotting cascade activation becomes overactivated and forms small clots. Widespread clotting in the microvasculature use up all the clotting factors. Patient now has excessive clots throughout body and depleted clotting factors. Clots can restrict blood flow to brain, liver, and other organs. Perfusion assessment, because you want to see it clotting anywhere, so clots that restrict blood flow to the brain, to the liver, or other organs. You want to look for low flow to the feet. You're going to be looking for low flow to the extremities, and then of course looking for stroke signs, heart attack signs, or signs that the kidneys are clogged, which could be low drawing output. DIC causes tissue damage, trauma, obstetric complications, when you're having a baby, so pregnant women are at high risk for DIC. Neoplasms, hemolysis, fat embolism. Anything that damages the tissue can set off this cascade. Vessel damage, aortic aneurysm, acute glomerulonephritis, hemolytic uremic syndrome. There's damage to the small vessels in the kidney. Infections, bacterial infection or sepsis, viruses, fungi or parasites. Important nursing care and interventions. Monitor oxygen saturation continuously. Admin. O2 as prescribed. Arterial blood gases, ABG, because you want to make sure that you're getting good perfusion to the extremities. Monitor LOC and mental status, vital signs, so this is gonna be looking for stroke symptoms to make sure our clot hasn't gone to the brain. Monitor BUN and CR, make sure that the kidneys aren't taking a hit. Assess for pedigree, ecchymosis, and oozing of blood. Assess perfusion. How do we recognize poor perfusion? Good capillary refill less than 3 seconds, mental status, etc. Avoid positions that impair arterial and venous blood flow. Some patients like to lay in bed with their ankles crossed. That's actually not great for perfusion. You don't want them to be like twisted in weird positions. Does anything that is going to decrease blood flow is an opportunity for stasis of blood, which is an opportunity for more clots to form. Assess dependent body areas. If they're sitting in the chair, where are we going to assess legs and feet? Meticulous skincare. They're gonna be so oozing every time you stick them for a blood draw. It's just up knees anytime they have an IV site, they could just oozing, so making sure you're taking really good care of all of your dressings. Bed rest. Elevate HOB. They're going to be on bed rest because if there are high fall risk, it could be very detrimental to them to fall. You want to elevate the head of the bed. You don't want to leave them flat in case they do get some kind of clot. Pain management. Intake and output equals watch urine for blood. Exemplar. Disseminated intravascular coagulation, DIC, 1238. Diagnostic testing involved. Complete blood count, platelet count, low, coagulation studies, prolonged prothrombin time, partial prothrombin time, thrombin time, and low fibrinogen level on 2 consecutive readings. D-dimer elevated. D-dimer elevated. High mean over 0.5 risk for clot. 0.5 or less is normal. Prolonged PTTINR, it would be the one with the low fibrinogen in the low platelets. How do we treat DIC? Treat underlying cause, prevent further bleeding, prevent further thrombosis. If septic is the cause, you want to get antibiotics into them and start treating the infection. Administration of blood products. Fresh frozen plasma, for clotting factors, cryoprecipitate, for low fibrinogen, and platelets. If platelets start to get really low, you might have to infuse some platelets. Chronic DIC may require long-term heparin therapy. Supportive care to maintain life support, mechanical ventilation, control organ damage RT, downwards arrow perfusion. If they have a giant PE, they may need mechanical ventilation. You want to control organ damage and make sure that they're getting good perfusion. Red blood cells in circulation. This is for someone who has trauma, somebody who has a lot of bleeding and has lost a lot of volume. Fresh frozen plasma is something you can give that also comes from whole blood. It's to correct a deficiency in coagulation factors or to treat shock due to plasma loss from burns or massive bleeding. Concentrate of platelets. So this is, they just take the platelets out and you get those can go in very quickly and it's going to repeat your platelets. Cryoprecipitate is to treat the low fibrinogen. It's very rare that we ever give whole blood in the hospital. It's usually one of these 4.